Okay. Sorry everyone for the temporary pause because we are trying to convert into a platform that more people can join. Okay. To aid in our diagnosis, sometimes if the patient come with a vitreous hemorrhage of the media is not clear, we can actually perform a B scan to help us to delineate the giant retina tear and identify it. So to understand this, we maybe need to have a basic concept of how retina detachment and also posterior vitreous detachment look like on the B scan. So for retina detachment, usually is attached to the optic disc at both sides. And for posterior vitreous detachment, usually is not attached in the case of complete PVD. In the case of incomplete PVD, there will be one side of both sides is still attached in the optic disc margin. So usually for retina detachment, the membrane will be thick and folded, or it sometimes can be smooth. Meanwhile, for posterior vitreous detachment, is very fine and is very mobile, unless it sometimes can be quite thick and a bit rigid in the case with the neovascularization, these or some fibrovascular proliferation. So the amplitude wise is actually 100% if we compare to the choroid and sclera, or whereas for PVD is actually less than 100%. And we can also lower the gain in retina detachment. If we lower the gain, usually it still persists. Whereas with a posterior vitreous detachment, we'll see that it disappears. So for retina detachment, is quite limit movement. When you ask the patient to look up and down, means that the movement is less with the eye movement. Whereas with PVD, you can see that the thing is quite mobile. There's also some associated features that can help you to identify whether it's a retina detachment or PVD. So move on to that. So from here, actually, I want to illustrate there's actually what are the classical signs for the giant retina tear on a B scan. So from here, you can see that there's what we call a classical double linear echo. From here, you can see shown by the orange arrow is actually a two high amplitude linear echoes. One is actually extended from the optic disc, and from here, extended from the optic disc and then the other one is usually lying almost parallel to it, which actually is the inverted posterior flap. So sometimes, as in this case, maybe it's not too obvious, you can see that actually there is some PVD already formed here. So this is a suggestive feature is because when there is a discontinuity in the retina echo anteriorly, and it actually extending more than, is suggestive that there's a discontinuity here. Actually, it is suggestive that it actually extending more than one quadrant. And this double linear echo happens is actually the two layers of retina is actually is in close proximity to each other. So from here, you can see that this one is actually follow the globe contour, whereas the other one is actually already free flowing, but it lies parallel to each other. As well as from here, you can see also the classical double linear echo. And from here, the vitreous opacity is actually likely will represent is a concomitant vitreous hemorrhage. So the main differential diagnosis for us is to differentiate it from the retina dialysis, because for both of these, it's actually also can look almost similar at first glance because it's a circumferential tear that actually happens can be more than usually extended more than 90 degrees. So what is retina dialysis? By the name itself, dialysis actually means separation. So it actually is a detachment of the retina itself from the insertion at the oral serrata. So it happens at the oral serrata as compared to your giant retina tear. It actually happens at the posterior border of your vitreous base. So in this case, there's usually no PVD. So the vitreous is actually still adherent to your both anterior and the posterior retina edges. So as demarcate from here with the black line, actually this is to show that the area of the giant retina, the retina dialysis that extended quite a few clock hours. So the actually beneath, posterior to it, here is actually the vitreous is still attached to it. So that's why you can see that the flap is the flap is actually is not as freely mobile as just now that it actually fall over and cover the macula. And in certain cases, you can even see that it actually, in a scallop edge shape, we actually follow is corresponding to your ora celata. So again, this is a cross section of the eye that to show that how the retina dialysis differs from the retina giant retina tear. So because of the still there's a presence of the adhesions of the vitreous adhesion that spans the break and adherence here to both the anterior and the posterior retina edge. So it's actually provides some form of stability to your posterior retina edge. So that's why you will see that it differs a lot from giant retina tear after you look closely. So from the B scan wide, it actually you need to do a multiple session to really illustrate it is really a retina dialysis and not a retina detachment. And from here you can see that it's actually quite rigid, but this is only one cross section. And I just want to illustrate here is don't have the typical sign of it's not continuation with your optic disc here, and then it don't have the typical double linear echoic sign. So this is very important for the clinician as well as for the VR surgeons because it determines the type of surgery and procedure later on. So the key points to differentiate a giant retina tear and retina dialysis is both can actually extend circumferential and can up to several clock hours. And both also, sorry for the typing error, both also can cause by trauma, and the common site are the superior and also inferior temporal, which are the cope and counter cope area for your blunt trauma. And the retina dialysis is actually occurs at the insertion of the retina at the ora serrata, whereas your giant retina tear occurs more posteriorly. Again, I emphasize is at the posterior border of the vitreous base. And the retina dialysis actually has an intact overlying vitreal retina surface that there is a stability there. Whereas the giant retina tear already got a posterior vitreous detachment in which the posterior flap is free flow. So this picture actually just want to show where is the exact location where you have a retina tear, in which this is a normal retina tear where you got a giant retina tear, it just extends more than 3 clock hours. Whereas the dialysis is actually occurs at you can see that there is no anterior flap here, and then it's just a disinsertion at the ora serrata. So what are the treatment options that we can actually offer to patients with giant retina tear? So these are we can offer based on the configuration of the giant retina tear. And so the treatment options are laser, photocoagulation, or encycling sclera buccal with laser coagulation plus minus cryotherapy, or PPV with the insertion of the perfluorocarbon liquids, or vitrectomy with the buccal, or if we need to take out the lens, then there will be combined phacoemulsification with lancectomy with vitrectomy. So the challenges for surgeons basically is as we see for the photo that I showed before, usually the retina detachment is very large, bullous, and mobile. So this increases the difficulty for us in doing PPV. And there's also the vitreous attachment at the anterior margin of the tear, with the on top of the large and bullous mobile retina, this made the complete clearance of the vitreous traction is more difficult. There are also higher risk of the slippage of the retina in case of giant retina tear, and this will result in the retina folds, which also will happen through the macula. There are also higher risk for developing subretinal perfluorochoroid liquid or silicone oil, and also risk of redetachment and PVR is higher. So what are the ocular factors and patient factors that can determine the decisions for treatment? So for ocular wise, whether there is a presence of a retinal detachment, or whether there is a presence of PVR that we can see from the edges of the giant retina tear, whether it's folded or inverted, and how is the lens status of the patient, whether the patient is phakic, pseudophakic, or the lens is clear of cataractus, or whether there is any concomitant ocular problems such as vitreous hemorrhage, macular hole, or even intraocular foreign body that result from penetrating injury or trauma. All this will determine the types of treatments that we will offer to patient. And last but not least is the patient age. So in the cases with no retinal detachment, usually we can offer the patient laser photocoagulation. Usually it's at least 3 concentric rows of confluent white retinal burns along the edges of giant retina tear up to the ora serrata. This is to, as you can see here, is just how you barricade your retina tear. So this can be done with the aid of the LIO with sclera indentation. Cryotherapy is not encouraged because it can cause a lot of inflammation and the risk of increase the risk of the PVR. However, sometimes is needed to enhance the to seal off the horn of the giant retina. In the cases of retinal detachment, there is no other choice that we need to offer the patient surgery. So in the cases with a no folded or inverted flap, which suggestive that no PVR, we can actually offer the patient cerebral with laser therapy most of the time, or plus minus with the cryotherapy to enhance to seal off the horn. In the cases with the folded and inverted flap, usually we can offer the patient PPV with the injection of the heavy liquid, or plus buckle, or even include the removal of the lens. The surgical goals for to repair a giant retina is actually to prevent slippage intra and post-operatively, and also to prevent the retinal detachment post-operatively, which means that we aim for the single surgery anatomical success. So what we meant here by slippage is actually the posterior displacement of the fluid under the retina. So it usually occurs during the fluid air exchange procedure, or even sometimes it can happen during the fluid silicone with the silicone heavy liquid and silicone exchange procedure. So this is caused by as you saw, so this photo is actually to illustrate the slippage of the retina here. So it's actually caused by the incoming bubble endoterminate, such as air or silicone oil. So this is a better illustration on how it happens. So when there is a air heavy liquid exchange during the procedure, we can see that we are injecting air through an infusion line here. So when the air bubble enters the eye, it actually forms that the base here is a relatively flat bottom face. You can see here, as compared to your heavy liquid here, it's actually the surface tension intersurface tension is actually more like convex. So as you introduce the air inside the eye, so this will actually displace the fluid, the aqueous here posteriorly, and on top of the retina is actually the retina is actually here. It's actually held by the hold by the surface tension of your heavy liquid here. So the aqueous is actually trapped in between your air bubble and also your heavy liquid. So, and as you introduce the air further, the aqueous actually can displace posteriorly as you remove the heavy liquid. So, as from here, you can see that it actually causes the fluid to actually displace posteriorly underneath the retina, and then this results in the slippage of your retina edge. So it will result in the retina fluid causing the retina fold around the posterior pole. And the peripheral edge of the retina, of the gyro retina tab, also will displace posteriorly and leaving an area of exposed RPE, and this will subsequently increase the tendency for PVR because of the exposed, the release of the pigments and the exposed large area exposed RPE, and as well as hypotony due to the increased uveal sclera fold. So in the case of the 360-degree retinotomy, so it actually can give rise to severe retinal fold and involve the macula. So there are certain intraoperatively operative steps that we can do to actually prevent it and enhance the success, our surgery success. First, with the placement of the infusion cannula and the sclerotomies, we actually, as I mentioned above, the retina usually is very freely mobile and very bolus retina detachment. So we need to place the infusion cannula with the care to avoid hitting the bullous retina and as well as to avoid subretinal placement by directing your inflow away from the gyro retina tab. So the main key point here, we actually need to release the vitreoretinal traction, especially as the anterior flap. So by doing this, we need a radical excision of the vitreous base up to the horn and removal of the anterior flap. In this case, we need to remove the anterior flap because it's already non-functional. So by leaving it, it can only induce PVR. However, to remove the anterior flap, in certain cases, it can be quite challenging, especially in the case of the phakic eye, and on top of the very bullous and mobile retina. So to complete the extensive removal of the vitreous base, we actually can help with the sclera buckle, as well as by sclera indentation. To mobilize, sometimes we need to inject the heavy liquid to help to immobilize the mobile retina to aid in the PPE. In certain cases, we might need to consider to convert into a 360-degree tear if we cannot release the traction. So this comes to the usage of the heavy liquid. Actually, the aim is to unfold and flatten as well as immobilize the posterior retina. Because most of the time, the patient with gyro retina tear, they will have some form of PVR because they are very high risk in developing PVR. So in most of the cases, we need to peel the PVR membrane. So if you imagine you are peeling in a very free flowing retina, so it's actually very hard. So that's why with this heavy liquid, it actually helps to flatten and tamponate the retina, especially in the posterior fold, to facilitate us to peel the membrane because it offers counter traction. And in certain cases, patient might have concomitant macular hole. You might also need to peel the internal limiting membrane. Then you need to stabilize the posterior pole. And heavy liquid also play an important role in reattaching the mobilized retina and to help in prevent of slippage. And sometimes it can use a short-term tamponade in which that we leave the heavy liquid for like 1 to 2 weeks before we exchange with silicone oil. So with the usage of this heavy liquid, it actually increased the primary attachment rate up from 50% to up to almost 95%. So here, actually, I want to share with you all a simple video of how we actually manage the giant retina tear by injecting the heavy liquid. Sorry that I don't have a really real life video on that. So this is quite a good video that can show that how the steps are being done. Okay. Okay. So from here, actually you can see that after putting the sclerotomy port, we initiate the PPV here. The surgeon is actually doing the core PPV here. And then you can see that the giant retina tear is actually here superiorly. And then you can see that the flap is actually very mobile. In this case, it's not a very bullous retina, but the area of retina detachment, as you proceed with the PPV, you can see that the flap is actually dancing around here. So the surgeon now is actually trying to inject the air to try to, after complete the PPV, he is actually trying to inject the air and do a fluid air exchange, air fluid exchange, and then you can see that he's trying to dry along the edges, along the margin of your giant retina tear. So in order to dry it up, you can actually rotate the eye towards the giant retina tear. However, you can see that the edges here is actually staged of here because there's a still collection of the subretinal fluid here. Okay, you can see the gapping here. So in order to overcome this, you can see that he tried to inject the heavy liquid to try to flatten and to push the fluid up here for complete drainage. So when we inject the heavy liquid, we try to inject it to keep the tip inside the bubble to reduce the risk of fish egg formation. Okay, you can see that there's an injection of heavy liquid here, and then subsequently it's kind of the flatten your retina here. Okay, we inject the heavy liquid up to the posterior edge here. And then he tried to drains up the fluid here. Okay, from here you can see very obvious, right? The gapping is no longer there as he dries up the subretinal fluid with the aid of the heavy liquid. Okay, after the fluid is completely drained from here, so you can proceed with the endo laser to try to sear it off. Usually we do you can do the 3 to 4 rows of the white confluence of the laser mark here to barricade around the area. And then the most important thing is a 360 degree to cover up to the Horn, what we mean is the end of the apex of your gyro retinal tear. So so subsequently with the direct heavy liquid and SO exchange, we also can help to prevent the slippage. However, sometimes the slippage can still happen if the fluid, when we inject the photo here is to show that actually the heavy liquid forms a convex bubble. The surface here is actually convex here under the fluid. So as we inject the heavy silicone oil here, you can see that the surface here is convex. So in between here is actually where the fluid is collected here. So it generally forms a circumferential fluid between your heavy liquid and also your silicone oil. So in order to prevent seepage, we need to make sure that this fluid over these edges need to be completely drained before we remove the heavy liquid. If not, the slippage still can happen here because there is a space here if the fluid is not completely drained. After this, for the choices of endo-tamponade, we sometimes can use heavy liquid as a short-term tamponade. We leave the heavy liquid inside the eye for 1 to 2 weeks, or we sometimes also can use a heavy silicone oil as a medium-term tamponade up to 3 months before we exchange into other endo-tamponade such as silicone oil. Sometimes long-acting gases can be used, but it still depends on the location of the tear and also the ability of the patient, whether they can position or the travel requirements for the patient. So this is another video that I would like to show how is the direct heavy liquid exchange with the silicone oil. Okay, this is just to make the sclerotomy port. Okay, so at this case, you can see that this is a very folded, the giant retina tear and almost a total retina detachment here. So there's also some form of vitreous hemorrhage here, in which that he is trying to do the core PPV here. And you can see that the retina is relatively very mobile when he proceed with the PPV here without the heavy liquid tamponade. Okay, he moved on to clear anteriorly. In this case, we can see that it's a pseudophakic eye, so that's why you can easily clear the vitreous at the anterior part of it. So now he tried to inject the heavy liquid to stabilize the posterior pole or the macula here. So usually we inject directly on the optic disc here and to maintain a single bubble. From here, you can see that the retina is actually slowly unfolded and flattened. With the aid of this silicone oil, heavy liquid, actually you can peel the PVR membrane if there's any. And then in this case, there was none, so there was a laser trying to seal off along the posterior border of the giant retina tear. And he actually did a 360-degree laser to prevent any redetachment or slippage in later on. So in this case, it actually changed the infusion to a larger ball for the direct silicone oil exchange. When he inject the silicone oil, actually the heavy liquid here is being removed. Of course, prior to this, we must ensure the rim of the fluid already completely removed before we inject the silicone oil. Okay, for the lens management part, there's actually depends on the patient. If the sometimes we can leave it untouched if the lens is clear, and especially in the pediatric cases, and in the cases when the lens is actually in the hinder us from a complete clearance of the vitreous anteriorly, sometimes lensectomy might needed, and we will leave it aphakic. Then if we remove the lens, we try to keep the anterior or posterior capsule intact for further IOL placement. Another option is sometimes we can place the IOL at the same time. Whether to buckle or not is actually still controversial. In certain cases, actually there are may associated with the increased risk of retinal slippage during the air fluid exchange. However, buckle actually can help to release the traction at the edge of dry retinal tear, where there is cases of flaky eye when we cannot do a complete clearance of the which we are fear of we cannot able to clear the vitreous completely at the anterior border. It also provides extra support for the rest of the vitreous base. And in the cases with a PVR present, sometimes a combined approach is more favorable. So this is one of the recent study that actually is a multi-center study that recently published last year to show that the vitrectomy versus a combined vitrectomy with scleral buckle in the treatment of giant retinal tear related retinal detachment. So in this case, it actually includes the pediatric as well as adult patients. In pediatric, actually the cutoff age is 18. So in this, the most important thing they want to highlight is the 1 year anatomy and visual outcomes are more superior for the combined PPV with SB than PPV in the pediatric cases. Whereas in the adult cohort, the outcome shows that there is no difference between eye treated with a PPV alone or versus the PPV or combined with scleral buckle. So this study is actually advocate that in pediatric cases, we do a combined PPV with SB, whereas in the adult case, we can do a PPV alone. So whether the determining factors for redetachment is based on whether the ages of the giant retinal tear, the traction is completely released, or there's any other misbreak, or there's any concomitantly any PVR formation at that time. And there's also reported cases, and the cases with the highly myopic eyes usually defined as more than 6 diopter, or there's a macular hole formation, they are more prone for redetachment. Outcome for giant retinal tear is the rate of reattachment following single procedure is actually up to 90%. However, it's lower in pediatric cases because due to the they are more prone for PVR developing PVR, and the final reattachment rate is sometimes up to 100%, 90 to 100%. In the cases with PVR formation, the visual prognosis is poor despite the reattachment and anatomical success. And bear in mind, most of the time, following the gyroretinal tear retina surgeries, they usually will have a secondary glaucoma, epiretinal membrane, and cataract as the commonest complication. The period of formations are actually based on the age of the patient. That's why pediatric patients are more prone to develop PVR. And the onset, the time of presentation, if they present late, so there is most of the time PVR already present. The etiology of the gyroretinal tear, in which in trauma cases, they are they are more likely to develop PVR. Whether there is any other ocular inflammatory disease, presence of choroidal detachment and vitreous hemorrhage also associated with higher rate of PVR formation. For the extent of the break, if the gyroretinal tear is bigger and larger, most of the time they are more exposed RPE and more high risk at developing PVR, and as well as the location of the break, inferior breaks are more prone for PVR. So how for the fellow eyes wise, till date, actually there's no consensus on whether need to prophylaxis or what type of prophylaxis we should offer, whether is it a cryo or laser or scarab buckle when we see an abnormal vitreous adhesion or white without pressure, or whether where to treat, whether just at the abnormal vitreous adhesion itself or up to the aura, or whether we should treat any lattice degeneration or the white without pressure or just barricade 360 degrees. There's still actually no actual consensus on that. However, just bear in mind that in fellow eyes or non-traumatic GRT, the incidence of having GRT in the fellow eye is up to 14%. So these are my reference, and thank you for being here with me. For the questions, there are questions on why we need to remove the anterior flap, and is it okay if we just leave it be? So to answer your question, actually the anterior flap, there's still, as we mentioned earlier on, the PVD already occur. So there's no vitreous traction at your posterior flap. However, there's still vitreous traction at your anterior flap. As we know that any form of vitreous traction at the flap, it actually leads to the subsequent PVR. So since the anterior flap is no longer functional, actually it's actually advisable to just remove it to prevent the subsequent PVR formation after that. And based on the vitrectomy versus combined vitreous sclera buckle, so in adult case, combined vitreous sclera buckle still have a role, especially in the case that there is a phakic eye that you do not wish to remove the lens, so you have difficulty in removal vitreous base thoroughly. So with the aid of the sclera buckle, it actually helps to stabilize, provide some support at the vitreous base there. So there's still role of the combined surgery here. So okay, it's almost 1 hour now. If I shall end the session, but however, if there's any subsequent questions, can actually PM me lah, no problem. Thank you.
Thank you.